With the one exception that I'm going to make, which is for Gemma Lucas and Trevor Sytsma, who both became doctors. Different types of doctors, but Gemma on Tuesday, I think, and Trevor 3 weeks ago. So congratulations. And they're going to move us with that in, sorry, that was a bad joke, with the title Moving Shame. Thank you very much.
Great. So how does this work? Oh, okay. So just 1 second, I think, for our PowerPoint presentation. Suspense. Okay, I was going to say that would be. Here we go. Okay, great, lovely. Okay, yeah. Hi, everybody. So my name's Gemma. I'm a lecturer in human geography here at Exeter, and I'm presenting with Trevor, who is a resident in anaesthesiology at Duke School of Medicine. And together we're going to be sharing reflections on moving shame, which is an embodied creative methodology that I developed during my PhD, and which we've been adapting within medical education at Duke with colleagues including Dr. Will Bynum, who is here, yeah, great, lovely, and Dr. Jordan Burnett, who unfortunately isn't here with us today, but was a really big part of this work. Okay, so today we'll introduce the Moving Shame workshops, and we'll discuss the 2023 series that we ran for interprofessional health learners at Duke. And we'll talk about how we use the workshop to explore how shame can be engaged, not just cognitively, but through embodied relational practices. And we'll also talk about the evaluation that we developed together, which demonstrates the effectiveness of the approach. Cool. Okay. Yeah, so just first a little bit about the origins of moving shame. So, as I mentioned, I developed it during my doctoral research in human geography. And the idea was to explore how shame is not just an individual emotion, but a relational, embodied and spatial experience. So I drew on feminist theory, trauma studies, and what's called non-representational methodologies. And I collaborated with a team of yoga teachers, psychotherapists and artists. And together we created Moving Shame, which is a practice-based response to the difficulty of engaging with shame through language alone. So the workshops, I'll talk a little bit more in a while about the actual structure of the workshops, but the principle is that they combine trauma-informed yoga and somatics with body mapping, collage and dance movement psychotherapy practices, and other creative practices as well, but those are the main ones that we use. And I'm trained in all of these embodied methods, so I've got years of experience facilitating trauma-sensitive, somatic and creative practices across a wide range of contexts. Universities, charities, community groups, and increasingly medical schools like Duke. So today, we're just going to focus on the work that we've done together in medical education. So through my connection with the Shame and Medicine project, I began running Moving Shame workshops with medical students in the UK. And in those early sessions, I saw how students could begin to articulate and shift their experiences of shame when they first connected with them through the body. So instead of pathologizing shame, these practices offered a way to approach it with curiosity, care, experimentation, connection. And several students told me that they'd never had the chance to explore or express these feelings before. So these earlier workshops were largely one-time sessions delivered to groups, or they were a longitudinal series that were one-to-one, so focused on one-to-one partnerships. But then in 2023, I spent 3 months as a visiting scholar at Duke, I had the opportunity to work with Will, and we did something new with Moving Shame. So we offered a longitudinal series for a group of medical learners. And Trevor's going to tell you a bit more about that.
Thanks, Gemma. So, as if Will didn't wear enough hats already, at that time he also happened to be the faculty advisor for a group that my upside-down collaborator, Jordan, here and I started at Duke called Medicine in Motion. Medicine in Motion's mission is mostly to focus on enhancing the wellness and belonging of our different health professions education students at Duke through a couple different modalities, focusing on physical activity, philanthropy, and then interprofessional community building. Will connected Jordan and I with Gemma when she came down, and given our group's focus on using diverse movement practices to support the well-being of our students, we agreed that Medicine in Motion might be an ideal group to partner in implementing some kind of intervention centered on shame and embodiment in interprofessional medical students. But that left us with a question, which was who should be the target of an intervention like this? And to date, most of the empiric research on shame seems to be largely limited to the medical doctor profession. But we know that all interprofessional health learners, whether that's nursing students, physical therapy students, occupational therapy, and many others, are all theoretically still subject to the same triggers and individual factors and systemic issues that might catalyze a shame experience. So we felt that efforts to address the experience and impacts of shame in medical training really should be delivered across health professions, maybe with the goals of enhancing learners' individual well-being, but perhaps even helping to improve interprofessional collaborative practice at the same time. So stated a little differently, we wondered if approaching shame as this fundamentally human emotion in a sensitive and authentic manner could really have the potential to not only improve well-being and belonging, but better the communication practices, teamwork, and the ethical stances that undergird effective and functioning interprofessional teams.
Yeah, great. Okay, so just a little bit about the workshop design. So the Moving Shame workshop series at Duke was a 3-part program over 3 weeks. It was designed for interprofessional medical students. So our goal was to help students to engage with shame, not just intellectually, but through the body and in relationship with themselves and others. Comes next. Yeah, so each 3-hour workshop followed a consistent arc. So there's variability in every session, but there was always a structure that began with a shared meal to develop connection. And then that was followed by us co-creating a safer spaces agreement. And then we would move into trauma-informed yoga and somatic practices and other movement practices to support somatic awareness and also develop nervous system regulation. And then we introduced creative prompts. So we used podcasts like the Nocturnist podcast. We used graphic medicine. We used quotes and images that related to shame. And we used these to spark personal reflection and conversation. And then from there, we shifted into other embodied creative practices. So that's when we use things like body mapping, collaging, and other like relational movement-based activities drawn from dance movement psychotherapy practices to support non-verbal expression and relational connection. And then each session closed, so it's kind of like an arc where we're sort of building towards a peak, and then we're closing at the end with some kind of grounding practice and time for group reflection where we debrief and think about what happened. So the structure is sort of designed to move people from into internal awareness through personal expression to collective dialogue. So the idea is that shame becomes more feelable, more thinkable, more speakable, and more shareable over time. Great. And then there's just a couple of images from Moving Shame workshops, just so you have a bit of a visual of what it is that we do. Great.
Yeah, and at this point, we advertise the workshops to Duke's medical, physical therapy, occupational therapy, nursing, and physician assistant programs, and recruited the first 13 of 34 total responses we received, just to try to keep the workshop series a little bit smaller and more intimate and conducive to small group conversation. And I was in the unique position to be both a collaborator in putting the workshops together, but also a participant. But I had no foreknowledge of the content of any of these workshops, and got to really experience the novelty of each in a unique way. Some of my physical therapy friends like to use the phrase motion is lotion to describe how the impacts of movement can be good for joint health and whatnot. But really, I got to see the way that motion can really be lotion for having an ability to prime introspection in a way that can help us talk about these emotionally laden topics in a really vulnerable way. And it was remarkable how quickly this group of students were able to open up to each other and share some solidarity in the experience of talking about shame. But to really gauge the impact of the workshop series, we asked all the participants to complete brief surveys at 3 different time points. One right before the workshop series started, one right after the 3rd workshop series, and then a 3rd 6 months later. The surveys included the validated shame frequency questionnaire that the McGovern group discussed yesterday, the Center for Epidemiological Studies for Depression 10-item scale, and the GAD-7 scale, plus some Likert scales evaluating comfort and confidence engaging with shame and navigating interprofessional settings. Now, please bear with me while I try not to offend the sensibilities of our statistician, Heather, but I'll try to break down the stats. For each survey, we first used a Friedman test to see if there were any statistically significant differences amongst any of the 3 time points for these different shame, depression, and anxiety scales. And I've omitted those results here for space's sake, but also, because, spoiler alert, they were all positive. But then to really understand which specific pairs of time points were significant, we used the Wilcoxon test as a post hoc analysis to obtain both a p-value and a z-score, which, as I've been explaining, the z-score represents the number of standard deviations of change between the time points relative to our null hypothesis, which in this case would be no change or 0. So stats jargon out of the way, let's look at some results. We found significant and pretty substantial pre to post improvements in our measures of shame frequency, depression, and anxiety, which remained durable out to 6 months for everything but the GAD-7. We didn't assess the shame frequency questionnaire at the post time 1 time point, since that scale assesses the experiences over the previous 3 months, which would have been inclusive of the pre-survey administered 3 weeks earlier.
I know. I really wish we had more time. We've got so much more to say. But I think just to wrap up, beyond the numbers, I think what makes Moving Shame effective is its relational, embodied approach. And I really believe that creating space for learners to come together, to move together, to spend time together, to connect through creativity, creative practices, opens up new possibilities for reflection, empathy, and belonging. So we'll have to end it there because we've run out of time, but hopefully there's more time for questions.
Thank you very much. I told them that I would be brutal, and unfortunately I am. Our next speaker is Sara Press, whose talk is entitled Teaching Stigma in an Undergraduate Seminar. Thank you, Sara.
I'm just going to quickly make sure that the sound is working. So if I'm about to start a video, and if you don't hear anything, just please alert me.
I don't hear anything. Oh.
Well, it's about to come on after, sorry, but I will let you know. So thank you everyone so much for being here. I'm gonna start with a quick 30-second clip, and I apologize in advance for the poor video quality, but sound should be fine. So for context, the video you're about to see was filmed in the US in 1998. It features Bob Dole, the former Senate Majority Leader and Republican presidential nominee for the 1996 election.
Courage, something shared by countless Americans. Those who risked their lives, those who battled serious illness, When I was diagnosed with prostate cancer, I was primarily concerned with ridding myself of the cancer. But secondly, I was concerned about possible post-operative side effects like erectile dysfunction, ED, often called impotence. You know, it's a little embarrassing to talk about ED, but it's so important to millions of men and their partners that I decided to talk about it publicly. And after all, it can be associated with many conditions, including prostate surgery, high blood pressure, diabetes, or even smoking. And the point I want to make is there are many treatments available for ED, so my advice is get a medical checkup. It's the best way to get educated about ED and what can be done to treat it. It may take a little courage, but I've always found that everything worthwhile does.
What's a viewer to take away from this candid encounter with Bob Dole? For starters, Dole probably got a lot of money for this appearance. But more importantly for our purposes, Dole is displaying a new kind of courage that he's entreating other Americans to come forward and practice. That is, the courage to talk about ED. After all, it can be associated with many conditions, Dole reminds his audience, including prostate surgery, high blood pressure, diabetes, or even smoking. In other words, ED could be the consequence of another medical condition, one that has no bearing on a man's masculinity. In short, this Viagra commercial tells us, ED is a condition that should no longer be stigmatized. This commercial with Bob Dole was the first example of a destigmatizing intervention that Dr. Alan Brandt and I showed our students in an upper-level undergraduate seminar at Harvard on the history and culture of stigma. The 30-second clip addresses multiple aspects of stigma that we wanted to introduce to our students early on, including the role that a celebrity spokesperson can play in destigmatizing a condition, the impact of changing language around a condition to mitigate some of its associated stigma, ED versus erectile dysfunction, strategies to reduce blame and shame through educational efforts, and the ways in which stigma and disease meaning can change over time. In this talk, I'll share insights into how we curated course readings, structured assignments, and modeled this seminar as an incubator for destigmatizing interventions. Stigmas are historically and culturally rooted, and underlying all our readings, discussions, and assignments was the notion of picking a given stigma and seeing if there was an intervention that could reduce it. Our weekly readings centered on a variety of stigmatized conditions. While our introductory weeks lay the theoretical groundwork for understanding general features of stigma, each week following those first two focused on a specific disease or condition whose unique form of stigma warranted its own time and analysis. Drawing students to a course like this, we operated under the assumption that our group had shared concerns, and we were able to build on this collaborative orientation accordingly, empowering each student to bring their own experiences to their learning. Significantly, almost a third of the class were students with disabilities who had experienced stigmas associated with their conditions. And students' investments in destigmatizing these conditions became increasingly apparent as the semester wore on and everyone began developing their capstones. The principal assignment for this course was for each student to develop a plan for a program or for intervention to destigmatize a currently stigmatized condition or disease. A central premise of the course was that to conduct a successful and effective campaign of destigmatization, it was critical to understand and explain the process by which diseases become and remain a source of stigma. While the ultimate submission was a detailed plan for such an intervention and its implementation, there were several successive elements that became part of the final plan. Assignment 1 was a 3-page paper identifying an important and/or overlooked stigma that harms individuals and populations and inhibits their obtaining appropriate health care. Assignment 2 was an 8-page paper centered on historical and cultural analysis of the stigmatized condition that places it in a deeper context to understand the nature of the stigma and its significance, as well as obstacles to changing its social meanings and consequences. Assignment 3 was a 15-page paper or plan explaining how the proposed initiative would work at a social, cultural, and political level, including an analysis of strategies for its implementation and impact, and a proposed approach to evaluating the efficacy of the intervention. Interventions could be designed at an interpersonal, local, national, or global level. These projects could be educational, artistic, legislative, involve social media, games, simulations, and photo exhibits. A student could write a short play or illness narrative, produce a podcast or a YouTube video. In short, we wanted to support students in pursuing a wide range of approaches, disciplines, and rationales to reduce specific stigmas. In week 8 of the semester, we organized a destigmatization workshop to help students think creatively about what different interventions might look like, how to target a specific audience for maximal impact, and how feasible such interventions might be in terms of time, cost, and necessary connections to individuals and institutions. Here are a few examples of destigmatizing interventions we showed our students. Art Reducing Stigma is an online collection of art by the University of Rochester Medical School's artist-in-residence, Skyrme Wheatley, who paints portraits of people with HIV/AIDS and other stigmatized conditions and incorporates aspects of sitters' life stories into her portraiture. Through Positive Eyes is a collaborative photo storytelling project comprising hundreds of people across the world with HIV/AIDS. The main photographer, Gideon Mendel, teaches individuals with HIV/AIDS about photography and empowers them to photograph themselves as they'd like to be seen. We also showed students how powerful changes to language can be for stigmatized groups. Here you see suggestions from the Recovery Research Institute for changing the phrasing around addiction to mitigate some of the blame and shame typically associated with the condition. Activism is another powerful avenue to reduce the stigma associated with a given condition. We showed students images of the protests at the Harvard Art Museums in 2018, which sought to have the Sackler name removed from the museums to protest the family that owns Purdue Pharma, the company that helped manufacture the opioid crisis in the US. Here's an artistic rendering of what another intervention at the Harvard Art Museums might look like today, 7 years after that initial protest. This example demonstrates how an artistic prototype can serve as a template for an activist intervention. We also tried to convey how consumer culture can be an effective vehicle for destigmatizing interventions. Here you see a large corporation making accommodations for children with autism. Such a gesture not only makes toy shopping more accessible for children with autism, but it also raises awareness about the sensory overload such individuals might experience in public spaces. And finally, we wanted to emphasize that destigmatizing interventions can sometimes backfire, as you see here with this campaign intended to raise awareness about postpartum depression. Failed interventions we showed our students can teach us as much about the drivers and reducers of stigma as effective ones. At the end of the semester, we organized a conference-style day of presentations in the room you see here, and recruited 3 public health professionals from across the university to serve as panelists and provide the students with constructive feedback on their projects. This day was the culmination of a semester's worth of work, and it foregrounded how much each student had learned about the nature of the stigmatized condition they'd invested in, as well as what kinds of people were often affected by it, and what demographics most needed to be targeted in raising awareness and reducing harm. Some of the final projects included the design for a chatbot that could help students with disabilities navigate accessibility services on campus, a prototype for a digital simulator that would replicate the physical symptoms of someone with Tourette syndrome to educate children about the condition, a comedy play about type 1 diabetes, and a photo exhibition on sickle cell disease with photos provided by individuals in the community who have the disease. In closing, while teaching the seminar offered us more insights into the history and culture of stigma, it also taught us so much about the ingenuity of our students, their passion for destigmatizing conditions that often affected them personally, and how powerful the seminar space was, not only as an incubator for destigmatizing interventions, but as a catalyst for community. Thank you so much for your time, and I look forward to hearing your questions.
Thank you very much, Sara. I have to say, we didn't plan on having 3 people called Sara on the same panel. That was not something that we had kind of thought about in advance. But it gives me great pleasure to invite Sara Kim to speak to us now about deconstructing and reconstructing the anatomy of the physician, an examination of the body as a place of shame in physician identity development. Thank you very much.
Great, good morning, or good afternoon, everyone. It's morning here in Toronto, Canada. I'm just checking to make sure that you can see the slides as they appear to me. And I'm going to take that as a yes. Okay, so I entitled this Deconstructing, Reconstructing the Anatomy of a Physician. I'm a physician myself. I'm based at the University of Toronto, and I'm an assistant professor in the Department of Family and Community Medicine. And what I'd like to actually just preface is that I'm intending this to be more of an experiential type of 10 minutes. So some of the things I might glance over the data, but more interested to hear from the audience what you experience as I give samples of what I do with the medical learners. And this includes medical students, residents, as well as faculty. So just as disclosure, I have no things to disclose, and I feel like mitigating bias is a lifelong task, but there's nothing directly affecting this presentation. I am also going to acknowledge that in Canada, we have a very difficult history to reconcile with our Indigenous peoples. And when related to the medical profession and healthcare professions, it is something that we do choose to pause on as it relates actually to this talk in terms of how historically embedded structural violence that we have participated as a healthcare profession is something that we directly need to address as we move forward for a more inclusive and equitable society. This is my disclaimer. So I am going to take you through some exercises, and they are intended to cause reflexivity and reflection. If you happen to have a pen and piece of paper, I invite you to jot down things as I move through some of these slides. So the objectives here are listed. I'm not going to read them through in the interest of time. Essentially, this talk was set up to be able to normalize the experience of our complexity and fallibility as humans, and also to cultivate a critical consciousness of how structurally embedded ideals and its reproduction have negatively affected those who work in healthcare, not just in terms of how we interact with patients, but how we regard ourselves. Now, disembodiment. This idea of fragmentation of the body is something that began a lot with Michel Foucault's work, in particular on the medical gaze. Often it's applied to thinking about how we treat patients. And here I've, over time, where this comes from is I still work as a semi-professionally as a contemporary dancer. And I would notice a difference from when I left clinic and then when I would enter studio, is that when I would enter studio, I would feel like I wasn't in my body. And this started, over 20 years ago as a med student, trying to understand like what was this juxtaposition of relationship to body, and what was it that my training was telling me as I moved through. And I'm interested in having everyone take a moment here to perhaps notice as you sit here how your body is feeling, or if that's even difficult to do. Do you feel more of your sensation in the head? This is this is an academic setting, or are you able to be aware of what you are actually feeling in your body as you are sitting or standing, listening to this presentation? Fragmentation of the body poses the body as an object of control and a place of domination. And this theme will come up as I continue in the talk. So where we go from here is the idea of shame as a technology of power. It's a tool of discipline, and it's also a tool of enforcing norms. It internalizes control where practitioners, as well as patients, learn to silence their distress and apologize for their bodies or accept inferior treatment. This deflects attention from systemic violence by casting suffering as a personal failure. And it also reinforces structural hierarchies, and also structural hierarchies that are internalized within the self. Now, as a reference point in Canada, for example, our institutions were really nailed as solid places during the early 1900s, late 1800s, in particular with the Flexner Report. And I often ask learners to consider who defined the standards and who shaped the lens through which we are taught to see and listen, and how has this influenced our medical culture, history, including healthcare culture, and professional identity development. I often then show the slides of a chart. This is taken from the Schwartz Center in the United States, which does a lot of work related to cultivating compassionate systems of care. And have the learners look at the middle section row, looking at the guiding ideals and how they have been strengths and have allowed people to get into medical school or the health profession of their choice, but how they become vulnerabilities and why they become vulnerabilities. I always say to the students, it's a fairly known thing that people who get into medicine tend to have avoidant personalities, or we suppress distress with eyes on the prize or always looking ahead. And this becomes reinforced throughout medical training. I was really struck with this statement during the pandemic, listening to a podcast by Terry Real. And what I began to think about and often present to the students to consider, the learners, is this idea of embedded contempt in our healthcare institutions and medical culture, where it's not necessarily rooted in care, but it's rooted more in contempt of the body, contempt of emotion, and contempt of human fallibility, and how we tend to judge ourselves according to that standard. And I also often praise this, where it reminds them that they are also people. This I do tie into fatigue risk management, is how we're phrasing it in Canada, or burnout, where the historical misconceptions is the body is an object of control and that emotions are a place of shame. And what I'm trying to affect in many of these sessions is to really understand that the body is inseparable from the person, and that healthcare is inherently emotional because it is a relational space. And the educational gap is how to navigate this emotional relational space from a place of humility, curiosity, and courage. And this is often what we go into during the workshops that I give to the learners. And again, I invite you to take a moment for yourself to think about how you perceive the space of healthcare, and whether you have, you do feel like it is one that is inherently emotional, or what professionalism and objectivity are actually about. So I take arts-based approaches. As a dancer, I often take the students through movement improvisations. I never tell them it's dance. I call it mindful movement when I'm in that context. And I also take them through drawing exercises, reflective writing, as I do have training as well in narrative medicine. And it's always through a trauma-informed approach. As part of my practice, I am a trained psychotherapist with the schools of internal family systems and the Center for Mind-Body Medicine in the US. So one reason we often choose art is that it's a means of questioning and giving voice to the voiceless ones in all of us, the things that are sometimes hard to put in words, and often doing actions or writing where it doesn't have to be verbalized allows access to personal truths that often cannot be stated aloud. So looking to the future, what I am trying to cultivate here is a pedagogy of care and embodied gentleness, not one that continues to be rooted in contempt, domination, and control. And gentle dialogue here is moving away from this idea of shame and blame, and moving away from the idea that care for self is a self-indulgence. It's in fact more self-preservation and a practice of establishing healthy boundaries, which is something that is actually quite often violated in medicine. And I think what I'll do is I'll end with just people jotting down how this presentation landed, because I'm very curious, and I hope you are also curious of how some of the language has landed in your body and the thoughts that arise. And I look forward to the questions that come up at the end. Thank you very much.
And we're within time. Thank you very much, Sara. So if you do want to take a minute, I'll give you a minute. I'll be timing it, but you can have a minute. Thank you very much. Our last presentation is Sara Skyrme, who is going to be talking about the downplaying of hepatitis C and its consequences. Thank you very much.
Hi everybody, I'm going to hopefully share screen. I'm hoping you can see that. Yeah?
Yeah.
Yep, okay, thank you. All right, yes, so I'm going to take you briefly through my presentation. So I'm going to talk about hepatitis C, which is a blood-borne virus that affects the liver. It causes brain fog, itchy skin, digestive problems, joint pain, fatigue. It can lead to liver cirrhosis and even cancer. The virus is transmitted through blood-to-blood contact, such as contaminated blood transfusions, unclean medical instruments, tattooing equipment, and it's also associated with needle sharing and illicit drug use. I'm a social researcher who has unfortunately had hepatitis C, and that experience has shaped my knowledge of living with a condition that can be difficult to tell people about. It can be very shameful and it can lead to stigma, and it can become a type of self-censorship where you don't disclose to people. When I was diagnosed some years ago, there were very limited treatment options, and it was an isolating, frightening time, both due to feeling terribly unwell and because I was restricted in who I could talk about, who I could tell about my condition. Here in the UK, there has latterly been an inquiry into what has become known as the infected blood scandal, which has raised the profile of how patients with bleeding disorders such as haemophilia and patients receiving blood transfusions contracted HIV and hepatitis C through contaminated blood products. Unfortunately, they then passed it on to others in some cases. I followed the findings of the infected blood inquiry, and it indicates decades of cover-ups, withholding of the truth, and missed opportunities to limit the spread of HIV and Hep C. I wonder how the systemic failure to communicate the risks has led to prolonged suffering and stigma, and how this has shaped my own experience of being ill with Hep C. According to the chair of the inquiry, this disaster was not an accident, but the infections happened because those in authority, doctors, the blood services, and successive governments did not put patient safety first. The response of those in authority served to compound people's suffering. Of relevance to patients like me is the implication of what this has meant when experiencing poor health and struggling to get a diagnosis. My own experience and that of others has been one of obfuscation, of GPs blaming my symptoms on depression, of me suffering in silence like other patients, and a lack of information about Hep C. No information on getting tested or what the symptoms might be. Admittedly, they are quite diffuse and diverse, but horrible symptoms at times. Research and reporting, including that by the inquiry, now indicate the government and NHS wish to avoid a bottleneck of patients with Hep C once they realise the scale of the problem caused by patients receiving infected blood. Testing and tracing and public communications were limited. The inquiry and the events it uncovered indicate failures of medical care, a collective failure to act, a failure of compassion and empathy among public health professionals and government officials. They chose procrastination over action. For patients with Hep C, the absence of Hep C resources in medical and other spaces was experienced not only as a barrier to awareness, but also acting to compound Hep C stigma by rendering the experience of those living with the virus unimportant, irrelevant, and invalid. This silence impacted mine and others' experiences of illness, causing years of suffering with poor health before finally getting a diagnosis, then feeling culpable and ashamed of that diagnosis. For those carrying viruses like Hep C and HIV, they're less seen as victims and more agents of contagion. I can't undo what happened to me and other patients, but I think that shame and its associated negativities can be countered or at least challenged through speaking out. And I've been working with an animator using music, imagery, storytelling to explore things that are hard to explain or hard to depict. I've used the growing body of graphic medicine, which some of you may have heard of, as inspiration and theory. And with the animator, we've produced a film titled In Spate, a fictionalized version of some of the things I went through. As I became ill, but didn't yet know what was wrong with me, the world seemed to be passing on. The objects that once contributed to the smooth, seamless running of everyday life became sources of obstacle, frustration, and even danger. What breaks down is the engagements of the body with the material objects that was once routine, easy, and smoothly operable. And in the film In Spate, we have our protagonist, Jane, who is starting to struggle with daily life, and we're going to watch an excerpt now as she struggles and as she realizes why she's unwell. For Jane, for me, for all those others who went through this process of realization, it was terrible. In the absence of reliable treatments, diagnosis was described as harrowing, precipitating a range of emotions including shock, angst, anger, shame, and overwhelming uncertainty. And in this next scene, Jane now knows she has Hep C and she tries to secure some social support benefits for herself because she's not well enough to work. And this echoes my own attempt to get some state benefits because I was too unwell to work. And I can tell you that it was the most humiliating and shameful experience. Yeah, unfortunately, we didn't secure those benefits. The way shame operates makes the individual feel alone with their dilemma, leaves them bewildered and unsure. It's hard to advocate from such a position particularly if you're feeling ill. So I had the health problem to deal with, plus facing the difficulty of seeking help with a stigmatized condition in the face of a seemingly uncaring social support system. I wonder if this would have been different if better support and knowledge had been available about hepatitis C. Testimonies from the inquiry reflect many people were too ill to work, wondered why they felt ill, and were fobbed off by clinicians who at best were poorly informed or prepared to help these patients. Hep C ravages lives and can lead patients to withdraw, seeing themselves as misunderstood, and when they ask for help, given very limited resources to help and support themselves. It leads to a kind of social death. Another element, I'm coming to the end now, another element when you have an infectious disease is it can be difficult going for the regular checkups that are needed. Blood tests for me were extremely fraught. I used to stay so still, not moving a muscle, because I was so afraid that the nurse might become exposed to my blood. And in fact, my Hep C nurse was absolutely wonderful and was a vital source of help and support. But really, without him, I would have so struggled. Finally, I wrote a blog post for the Shame and Medicine project, and then we produced a very short animation to go with it, which I'm going to show you now. And it depicts how patients with Hep C and other stigmatized conditions might like to be treated. Living with hepatitis C requires regular health care, but appointments can be fraught due to the associations with illicit behaviours. Clinicians may not know how to talk to patients, and shame, blame, and stigma can cloud and impair interactions. Patients frequently struggle with poor health, financial worries, and awareness of how others may view them. And their help-seeking behaviour can be limited because of this, furthering their isolation and self-censorship. Those who already feel marginalised can benefit from supported, non-judgmental healthcare encounters, where the selfhood beyond the disease is recognised and validated. Treating the disease is not the same as treating the whole person. And in wrapping up, I'm just going to mention that antivirals came out of clinical trials in roughly 2015. I wasn't able to access them because they were so expensive by the NHS. They were only giving them to very, very sick people. So I joined a buyer's club and bought my antivirals, and I was cured. So it's in the wake of that experience that I wanted to speak up and talk about my experience.
Thank you very much, Sara. That was very powerful. I'm going to invite all 5 panelists to come virtually or in person to the front. What we'll do is we'll do one question from the floor, one question online, and I think we'll spill over into the break somewhat by 10 minutes, if that's okay. Great. Any questions?
Hi, Anna from King's College London. So I've got a question for Gemma, Trevor, and also Sarah Kim. So I really loved hearing about the kind of embodied nature of the work that you're doing. I'm lucky enough to work with some wonderful medical humanities colleagues who do practice-based work within our medical school. However, we've found that our students are very resistant to movement-based practices. And I just wondered if you had encountered the same resistance, and if you have, how have you overcome that?
Yeah, it's a really good question. I'm wondering if Sara I can go first. Yeah, so I've ran movement workshops that have both been compulsory and voluntary. So the shame work has always been voluntary. So it's always been, yeah, a sign up. And actually, we were talking about this earlier, that I've never ran a workshop that hasn't been oversubscribed. So the workshop at Duke, did you say we had 30?
Yeah, 34 signups.
34 signups. Yeah, and we had put a cap. And those are compulsory for first year and for fourth year med students. I mean, I think attendance has always, they're compulsory, so attendance has always been good. But yeah, it takes a while to warm up. And yeah, I think overall they've been really well received. We actually ran one at Duke for PT students. It wasn't compulsory. Oh, it was compulsory. That was a huge group. That was more than 100 students who came to that, and that went brilliantly. I thought the students were really engaged. They were always really nervous at the beginning, and it takes a while. I'm trying to think of an answer to what to do about that. I think it just takes. If you've done it a few times, you just kind of develop the skill. You sort of learn how to kind of ease students into it. I don't really know how to explain that. I think it's about the kinds of movement practices that you're doing as well. So I've definitely got practices that are more challenging and practices that are less challenging. So it's a really big group. Then definitely at least starting with less confrontational practices. I think Sara said using the word mindful movement rather than dance. That's another kind of really good tip. I'm veering away from using the word yoga, probably for similar reasons. I don't know, Sara, maybe you want to jump in?
Sure. Can everyone hear me all right? Great. Yes. Yeah. So I do sneaky things, like I never call it embodiment in the beginning. And I often, when I do, so I'm sort of in a privileged position in that I'm on faculty for the Faculty of Medicine. And so I do get 5 lectures with the first and second year students as a trapped audience because I'm the health humanities lead and those are their narrative medicine lectures. But what I tell them that we're doing is exploring what it means to have leadership presence. So I play a lot on this idea of leading with self. And because most people don't have a practice of some kind, I also play games with them. And what I'm doing here is I'm manipulating the neurobiology of how you get people who are uncomfortable in their bodies or connected in a different way to drop in. And when you bring in play is a way, play and laughter. So I get them to do goofy games as a quick warm in. And what I tell them we're doing is that we're doing an icebreaker. And then as their bodies start to get comfortable being seen, and the other thing I remind them is that no one's looking at you, you're looking at yourself. And so can you place that aside? And we're going to talk about that as we move through the rest of what kind of narratives you carry, where those narratives come from, and what it is you do when you start to go into body and how you carry judgment. And so it gives an opportunity to talk about narrative medicine. So that's a starter. In workshop settings, often people who sign up for the workshops already have a readiness, but that's a strategy I use. I borrow a lot. So my background, clinical training is actually in sports medicine. So I play on that a lot where I show them a little clip. This is a basketball player. This is what they achieve. How do they arrive here? And what I say is they have a physical practice. And as much as they have a physical practice, we also, and I also have the background of trying to get people to exercise. And so I use a lot of strategies of people who don't want to exercise and how you get them to move. And again, breaking it down in a very progressive manner that I feel is appropriate for the particular audience that I might be engaging. I hope that's helpful.
Yeah, just a really quick add-on to that, actually.
Gemma, if you use the mic.
Oh, sorry. I have quite a projective voice. So anyway, a quick add-on to that, because that is also really key, actually, when running these compulsory workshops for med students, is making sure that they're clear what the purpose of it is. And the purpose of it is usually much broader, actually, than what you tell them the purpose of it is. But having a few kind of clear learning objectives frames it in kind of a language that they're familiar with. And yeah, I mean, there's lots of examples I could give. Maybe we could talk afterwards. But there's lots of different ways to do that.
So there's an online comment I'll read, which is related to this, and then I'll read an online question. So Pascal says, I am running art-based and creative health classes for my PhD and found that explaining the effect of art and embodied techniques on the brain helps. About the brain. The question is, I'm interested to know if there is a hierarchy in acceptable people with Hep C, for example, those who got it through infected blood transfusions, and less acceptable people who got it through sharing needles, even when stigma does reduce a little. So for Sara.
Did you hear that, Sara? Sara Skyrme.
I'm sorry, I'm struggling with my volume. Could you repeat that?
I'm interested to know if there is a hierarchy in acceptable people with Hep C, for example, those who got it through infected blood transfusions, and less acceptable people who got it through sharing needles, even when stigma does reduce a little.
Yeah, definitely. But still within that, the overall sense, I would say, is we're still a collective group. Some of us, for example, don't know how we caught it, which is my own situation. So there's always that uncertainty. So I don't fall into the group who are going to get compensation through the infected blood inquiry. But I still, the fallout is still with me. I sold my house. I was very sick at the time. I sold my house at a huge loss out of panic, just to get it off my hands, because I couldn't see how I was going to pay the mortgage. And obviously, certainly here in the UK, you sort of, owning a property is a sign of kind of some stability. And it's taken years to get back to that point. So I kind of feel I'm in a weird situation. I'm this researcher with a PhD, but I'm also this person who had this stigmatized condition, and I'm not quite sure what your status is really. I don't get any compensation, and you kind of muddle through. It's a strange situation to be in, even to talk about.
Thanks. I just want to say thanks to all the presenters. They were all fantastic, and particularly acknowledge the final, Sara, your courage and vulnerability in sharing your own story with us is really powerful. But my question is back to Gemma and to Trevor. I'm interested in gender, and I just couldn't help but notice that it was one male in your group, Trevor. Big round of applause for you. Part of my role is running a leadership fellowship scheme, and I've offered workshops on shame and exploring shame as a leadership topic and how we move forward with it. And interestingly, only women came, and I had the fascinating piece of feedback from a man who told me that, well, I don't need to come, I've never felt shame in the workplace. So I'm just wondering if you have comments on A, the gender split, and B, how do we move beyond that kind of stigma, or what do you think is going on there, and what are the practical steps to include more people in the room?
I wish I had the right answer for you on that. From our perspective, our recruitment was completely voluntary, and we recruited, from those 5 different healthcare professions. And at Duke, all 5 of them are at least 65 to 70% occupied by people who identify as female. So inherently for us, from our recruitment standpoint, we're just so much more likely to recruit there. I think part of the challenge for us is kind of related to that comment that you obtained from a participant that said, I don't think I've experienced this, I'm not sure that I need this. And we've talked a lot during this conference about how acknowledging shame really early on in training as people are entering these pathways can help prepare a set of experience and language to start navigating and wrestling with these emotions. And part of me wonders if having earlier conversations in all of these training pathways to normalize it might be a strategy that might help subsequent interventions like this maybe reach more of that male gendered group. But I don't have a great answer for you, unfortunately.
That was in fact also my question, but I was curious then, if you said 34 down to 13, were all the other 33 also female, identifying as female? Okay, thank you.
They were all female. I abuse chair's privilege to ask Sara Press, what kind of feedback, do you want to talk a little bit more about the feedback that you were getting from the students? How did you run feedback? I might have missed it in your presentation because I was so obsessed with timekeeping, and I commend you for, again. Yeah, so do you want to, what did you hear from the students?
In terms of at the end of the semester or throughout the semester?
Yeah, well, actually both. I mean, it'd be quite interesting how things were developing and then what they kind of came to at the end.
Yeah, no, thank you for that question. So the assignments built on each other, and we did it so that, the first paper was then part of the second paper, which was then part of the third, which also involved developing an actual pilot intervention. And each assignment was an opportunity for the students to come meet with us during office hours. We also spent a lot of time at the start of class going around so people could share what they were thinking about. I had a few students who came to me and they, after the first assignment, decided to change the project because it was actually too hard for them to focus on the condition they initially wanted to focus on because of personal investment in it. Although, as I was saying, a third of the students in the class identified as students with disabilities, and that was a very broad range of students. We had someone who was blind, we had someone with cerebral palsy, POTS, which makes it hard to stand for long periods of time, dyslexia, diabetes. So it was a very wide range of disabilities that students had. But I think one of the things, and because of the 10 minutes, I could have probably spoken about it for an hour, but the actual seminar space itself, we really tried to cultivate it as a very safe space to begin with. And one of the things we tried to balance was having students draw on their own personal experience, but not making it into a therapy session. So still using all of the readings to have sort of this theoretical basis for understanding what a lot of them were experiencing. And the feedback from the students was really positive. I think having that workshop at the end of the semester, it was actually a 6.5-hour day. So it was a long day. We had catering, which helped a lot, but the students came to know each other really well, which was part of what we really wanted to do, was create that community. But we also noticed a lot of the students who were part of a disability activist group on campus came to us and just felt very seen by the fact that this course existed, because there isn't actually like a disability studies minor that exists. So this kind of gave them entry into having those conversations in a more formalized space. Yeah, so very positive feedback. The one piece of feedback we got was there were too many readings, but that always tends to be the case these days, especially. But the feedback was really positive, and one of the students actually ended up asking us if we could use this course as apply for something called like the civic action credit at Harvard. So we ended up getting our course counted towards that. So students, if they took a certain number of courses, of which ours then became one, they could get a diploma as well when they graduated. So it became much more of like a civic action, disability activist oriented course. And that was partly by design, partly just the students. So it kind of developed throughout the semester in this really cool way. Yeah, thank you for that question.
Great, thank you. Thank you very much to our 3 online speakers, to our 2 in-person speakers. For those online, I know that you can't see anyone. So at the moment, you're sort of speaking into this void, but just know that there's a very appreciative audience at the end of the void. It's not just blank space. So thank you very much. Hopefully you can hear some of the clapping over the microphone.
We're going to have a break, but John, would you like to come up and share? He's just going to speak for 2 minutes about a thing. I'll let him say it.
Thank you very much, Luna, for giving me this opportunity to just say a few words to gate crash the carefully planned agenda. You've already heard from me earlier on today, giving some details about a very early trauma in my career. I went on to become a GP in the UK. I retired 12 years ago, having had, well, I would say, a very fulfilling career, but not without its difficulties. I had a lot of mental health problems in my youth as a child, and although I managed my career, I still felt that I was different from most other people in the profession, let alone in the world. 7 years ago, at the age of 69, I had a private assessment at the suggestions of 2 of my daughters as to whether I was autistic, and it turned out, yes, I am. And the reason I am here is because only last week I discovered that one of the presentations today was going to be Mary Doherty, who has been such an inspiration to many of us in the profession and in the wider world. What I just wanted to say was, I've been catching up in my knowledge. I had always rejected the possibility that autism was responsible for my differences because I knew that I had empathy in the career that I'd done, the work that I'd done, which I knew was of value. Yes, I had empathy, but according to orthodoxy, we are not supposed to have empathy. We are not supposed to have theory of mind. So that turned everything on its head. So I've been learning a great deal since my diagnosis about what the truth is and how a lot of these myths and stereotypes are rooted in falsehood. I joined a Devon-wide, and this is the reason I've asked to speak to you, a Devon-wide group, self-help, mutual support group called Dimensions for Autism. And so those of you who have either, sorry about doing who have connections or, with patient care within Devon or know people, this organisation, Dimensions for Autism, is a website, all one word, but we have gained funding from Devon County Council to have much more of a proactive approach to helping to educate in all manner of means that may be possible, healthcare professionals, the general public, care workers, maybe teachers, maybe employers. And so we would very much welcome anybody who feels that we may have something to offer to enable that to go ahead, which is such an incredible need. As Mary's presentation so eloquently explained, it's not just the general public that is filled with myths and stereotypes, it's the medical profession and the caring professions. So I would like to play a tiny little part in what time is allowed left to me in the rest of my life to try to redress some of that. That's all. And I'd love to hear from, I'm happy for my email, my phone number to be given out to anybody who's interested. But if you're interested to know more, Dimensions for Autism on the internet. Thank you.
Thank you. And as many of you are working in Devon, I thought that was a relevant piece of information for you all. We have a break now, which is a poster session and a break. So please do, those who have come with posters, please do come and stand near your posters and let's all take a look and ask questions. And I think the cake is still out. Alice had asked them to thumb up. Yes. Half thumb up. Well, let's go see. Please eat the cake. And we'll come back at 3:15 for our final speaker. Thank you.
Some people.
Okay, we're doing it. Poster section is actually just pictures of each other. Where's such a
Yeah, I'm gonna do that.
So it attracts the people who else the good ones.
Yeah, totally. So that's exactly what that's
Whenever you get you should believe it. Oh, the Sixth Sense, that must be equally. Yeah, yeah, yeah. Exactly, yeah, because they're going to take a really break. Because they can't, yeah, exactly. Get rid of the NHS? It's never big enough. It's never big enough, is it? So that's why that's got like, I own all the newspapers, it's not enough newspapers. To this car. It's been cancelled. Roman Empire's been cancelled. You've lost your chance.
Almost over.
Hello. We're going to come back in a minute. Everyone who's milling around, come back.
Yeah, I think you're right. Yeah.
The most important person.
right. Welcome back, everybody. So we're starting 10 minutes after the scheduled start time. I'll just give everyone a minute to sit down. And just thank you for everyone. I realize that the online participants can't see the posters that were presented in the room here today, but thank you everyone who traveled down with a poster and had time to chat to us who were asking questions and having a look. It was like a whole nother conference on poster form over there. So much to take in. So thank you. So I'm really delighted to introduce our next speaker and our final speaker session of the day, which is Dr. Will Bynum, who probably doesn't need any introduction, so I'm not going to give him one. I'm just going to say this is Will from Duke University, and many of you know his work, and very looking forward to his talk now. Thank you.
Thank you. Gosh, what I mean, I'm so thankful for the opportunity just to share some thoughts, and I'm gonna take advantage of the opportunity to just share some thoughts. I'm not gonna really try to teach anything. There's been so much taught already. The richness of this conference has been so beyond expectation, and I also really appreciate the chance to go last. Because I've been in a very reflective state throughout this conference, and I thought, well, this could be a good opportunity to reflect a bit on what we've been hearing, from where we've come, where we're going, maybe with a little bit of wisdom. And then I thought, I'm too young and I'm too inexperienced to have wisdom. But then the hair on my ears grows faster than my head now, so I think I do. I think I've earned a tiny bit of wisdom, and it's not wisdom. If maybe it's just insights, reflections on where I think this topic is now in healthcare, having worked on it for many years now, and maybe most importantly where it's going, and then what the challenges are to taking it where it needs to go. And I think we're going to all agree where it needs to go, but there are some barriers we're going to have to consider and overcome to do that. I've featured some art from Hannah, who works with us a lot. Again, I just cannot praise her work enough. My journey to shame in healthcare started, as many of you have heard. I will not put you through it again, with an error. 12 or 13 years ago, as a resident, had all the features of so much of what's been discussed in these last few days, and it was a life career defining experience. I didn't realize that then. I can look back and say that it has been incredibly career defining. That one event. And if that doesn't tell you about the power of shame in a really positive way, in many ways, despite so much suffering that I went through, there's been such a positive experience from it that's come from work and thinking and collaboration and other people. But after I had the error, and after I got dumped by the bad girlfriend at the same time, and I don't know which shame was worse. They were different flavors, but they thankfully maybe. Happened at the same time, which really gave me the catalyst to sort of figure some things out. When I came back into my healthcare environment, having navigated the shame experience, having discovered shame, thanks to Brene Brown, and then having gone somewhat into the literature, I like someone said earlier, Mary said, it was like that aha moment. Boom, the shame bomb dropped, and suddenly I could see it everywhere. And not because it's just happenstance everywhere around us, but because shame is just part of us, and we are our world. I mean, it's our world in many ways. It's emotion, how we feel about ourselves. And so just being able to look at the world around me differently was very eye-opening. And what I found, both in my lived experience as a medical resident, in really my personal experience, and certainly in the literature that I started to delve into, I'm going to use, just this notion of an iceberg. It's so overplayed, but it's so apropos here, that so much of the experience of being in healthcare, in whatever capacity that may be, right, is seen and understood in ways that we can talk about, that we can measure, that we can test and retest, that we can fix. And so much of the actual experience of being in healthcare remains beneath the surface. Right? And Hannah nailed this image. If there's no better image of an iceberg to describe the shame experience, that swirling, humanizing, powerful, real emotion that is so wildly complex and so often remains beneath the surface. I don't know what better depiction there is. And as Luna and I and others have sort of pontificated about this phenomenon of the iceberg and things, we've started talking more, and I can't remember, I think you came up with it, Luna, somebody else, some other smart person. It wasn't me, I don't think, but I'm using it, which is this notion of the present absence of shame in healthcare. I mean, this is a present absence. It's present, it's happening, how couldn't it be happening? And yet, the recognition, the awareness, the interaction, engagement, the avoidance of shaming is absent. It's just not on our collective radar. Now, that's what I say to groups that aren't you, right? And it makes a difference. And they, you know, I can see the wheels turning. This group knows this. I mean, if this conference doesn't tell us that, right? This group understands that we're operating within a present absence and we're doing something about it. And that's super empowering. There's many other ways to apply this iceberg metaphor, though. And when we think about where we are with maybe the work of shame in healthcare, I think this also may be appropriate, right? We know more than we know more now about shame in healthcare, certainly than when I reeled for my shame error. I can tell you that. I can't decide if this, you know, of course, what we know and then what we don't know. There's so much we don't know yet. Every paper, every presentation, every theory, it just opens up more realms of understanding that are possible, right? Which is in part overwhelming and in part incredibly motivating. I can't figure out, I also just can't think outside of a metaphor. I just can't, it's not possible. I hardly can dream outside of a metaphor. Are we draining the water or are we lifting the iceberg? Because we are getting more of the surface. We're bringing more to the surface and above. Some days it feels like we're draining water. Most days it feels like we're lifting an iceberg, right? Our goal is to bring more of this authentic, hidden, stigmatized, lived experience into conscious awareness, acknowledgement, and acceptance. And it's gonna feel like we're lifting an iceberg sometimes. Mary, you've been through that recently, right? You acknowledge these last months. And that is the authentic work of being human and the really hard work of being human. To do this, I think, to bring shame where we all need it to be, we collectively, beyond this group in healthcare, to leverage its power, to mitigate its destructive nature and potential, I think we have to do more than just study it. We do need to study it, and I'm going to talk about how we might consider studying it as we move forward. But we've got to do, I think, kind of three parts at one. We need an empiric foundation for this work, and I'm going to elucidate some reasons why I think that is. We also need to be able to reach out about this. I think this group is particularly poised to do that, right? I mean, the eloquence with which people get up here, the vulnerability and share their stories and experiences and work is transformative. And then we need to build capacity for engaging with this emotion. We can't do one of these without the other. In fact, I think this is, in some ways, I think about this almost as a campaign of sorts. We have to campaign for shame to be a thing in healthcare. It can't just be something we kind of happen across, that one little paper or effort or even small conference here or there does. It needs to be coordinated and thoughtful, and we need to own this opportunity as a group of people that are capable of, I think, rising to this occasion. To do that, we've got to overcome some barriers. And I initially had the barriers to researching shame, and actually these are barriers to just advancing shame, just making shame real in our world, to making it a thing that actually happens and is acknowledged. And I've sort of broken these into four parts, and then I'm going to provide a few thoughts about each part and what we might do, and then we'll have a bit of discussion, hopefully at the end. Okay, the first barrier that I have encountered, and I think many of you will agree, is the dominance, and this is in our literature especially, and it's actually not just in our literature, it's in our lexicon, it's in our discussions, it's in our conferences, and that being the dominance of constructs that we can easily measure, maybe not even easily, let's just say measure, and talk about. And to make this example, the United States National Academy of Medicine is a big, huge governmental think tank academy. It's one of the main academies in the US. They sponsored a a clinician well-being task force a few years ago, and they brought together leaders from the American Association of Medical Colleges, the Graduation Medical Education Council, the AMA, Victor Zhao, who is the chair of the IOM Institute of Medicine, led it. Amazing collaborative effort. And as a part of that, they created what's called a knowledge hub. Okay, so they pulled, through some methodology, I don't know what it was, but they pulled together all sorts of resources around clinician well-being that the user of this interface could go and use as references. So I was thinking, cool, this is a great resource. I wonder what each of these will bring up, right? Selfishly, I was like, I wonder how many of my articles are in here. Did they make the cut? No, they did not. In my search, I think it's revealing about the status of our science right now. These were the numbers of articles that came up with each of these keywords, and this is reproduced days ago. This initially I did it a couple of years. 5 articles on shame. Not a single of those 5 is actually about shame. I don't know how that works out, and none of mine, and then or any of yours. 462 articles on burnout. And in fact, this whole task force is really it was like the task force to address health professional well-being and burnout. I was flying into New York recently, a little while, maybe when I was first thinking about this a couple of years ago, and this is the kind of the Upper West Side of East Side skyline, which is evolving into this goofy set of very tall, very thin, extremely expensive buildings. And I looked out the window, and I thought, and I looked back, and I was like, that's exactly what our science feels like, right? I mean, this is how it feels, talking to the average person about what it means to be well or unwell in healthcare. Essentially, the essence of those experiences is especially captured in the notion of burnout, which is attempting to explain everything about this wildly complex phenomenon, sometimes in 1 or 2 item scales, which is just mind-blowing. Right, and I think if we continue down this path of doing good work, right, the burnout literature is good work. It's one of the reasons it's so dominant. It's really well done. If we keep going in this vertical manner and building upwards, we're going to lose complete sight of the breadth of the experience of what it actually means to be in this profession, as a patient, as a clinician, as a staff, et cetera. All right, so we've got to work on expanding what's possible, okay? And one of the things that holds us back from doing that are the epistemological and ontological paradigms that anchor our science, okay? And I'm not going to, I barely understand what that means, but I'm not going to go into detail about what I mean by this. In essence, what I'm talking about is the assumptions we make about knowledge and about what it means to be. And those assumptions are heavily weighted in healthcare and in many of our scientific disciplines, namely psychology, and the assumptions that phenomena in the world happen, they occur in predictable ways, there are singular or ultimate truths about those phenomena, and if we just design the right experiments, we can get, if not to that truth, meaningfully steps closer each time, right? But there's a fundamental belief that the world is established and set up in predictable ways that can be proven. And that is a massive barrier to advancing this topic, okay? Because I just pulled a random table from a random paper from a psychology study. If you spend much time in the psychology literature, it's just, what's the word? I mean, exhausting, impenetrable, thank you. I sat in a dissertation. I was a dissertation committee of a psychology PhD just last week on shame and borderline personality disorder. And I really, really struggled to find the meaningful takeaways from something that was so carved up, and quantified, that this is the story of shame that those paradigms will dictate. Now, I'm not saying there's not a story in this, and I'm not saying there's not huge value in this, and I'm going to contradict myself in a minute by saying we actually need more of this, right? But we need to recognize that only remaining in these rooted paradigms is going to severely limit our ability to advance this topic in healthcare. And I'll talk a little bit about how we might balance that. The third, and you all are definitely going to resonate with this, is the reticence, pervasive reticence to directly address this, i.e. say it, call it by what it is, acknowledge it openly. And that's not the fault of anybody that is reticent to do that. That is, in many ways, the function of this emotion, right? That's just the complexity of working with it. It's how it operates. It's no one's fault, but it's a barrier nonetheless. And I'm going to just give you 3 examples of this that I think really highlight this point. So I was talking to a scholar at the I'm going to say the university. I don't want to give anybody a bad name. A scholar at a great American university who put together a course, elective course on helping medical students explore their experiences of shame through creative media. And she reached out to me just to let me know how it was going, and they used our podcast episodes. And I just said, well, how was it received at your university? And she said, well, in some circles really well, in others not so well. And I said, well, how did you get it through for credit? And she said, well, we just put together this really robust curricular document. And really the biggest thing though is that we had to change the title in the registrar, right, in the list of courses. And I was like, sure you did, I know. What did you change it to? And she was like, well, much to our chagrin, the dean's office came back and said we had to call it Exploring Professionalism in Medicine. I mean, that's not a whitewashing of shame, right? And we were both like shaking our heads. God. I was up at another great university in the US, and I was doing a kind of multi-day site visit, and one of the most fun meetings I had was with a group of clinical psychologists who were working with, they were embedded at this university with residency programs. So each residency program had an embedded psychologist. 50% of their time was focused, dedicated on providing them support. And it was not therapeutic support. It was really meant to be kind of coaching and some mentorship and low level, maybe psychotherapeutic interventions, but nothing too deep. And I was like, oh, so excited to talk to them. I said, how often does shame come up in your work with residents? And they were like, oh, all 8 of them, like, all the time. And then I said, how often do you directly ask them about their shame? Like with the word shame, group of clinical psychologists. And everybody got real quiet. Nobody said anything. And one woman just to my left spoke up, and she was willing to just speak on the matter very openly, and I really appreciated that. She said, no, we don't do that. She was like, it feels too personal, and it's too risky. These are psychologists, trained. And I just nodded and gave her a minute, and I gave her a second, just nodded, non-judgmentally, and then she stopped herself and she goes, and she didn't even think about it. She was like, yeah, we talk about depression and suicidality when they come up. Like, that's okay. It's okay to ask about those things, but just not shame. And that's when I kind of raised an eyebrow, just ever so slightly, reflexively. And then everyone was like, oh, shit. They were like, wow. It was an amazing aha moment of the stigma around this emotion, the perceived risk around it was preventing them from asking about it, when really, in so many ways, it's just asking someone what it's like to be a human in a hard space, right? And it's probably sitting underneath the things that they were actually asking about. Finally, most proximately, Luna and I wrote an article for American Family Physician, curbside, like practical thing about what's a shame-confident response to medical error. And they wrote back and said, the title is difficult for the uninitiated reader to understand. It could be off-putting. I suggest a more direct title, such as Supporting Colleagues After Medical Error. And we got this and we had a good laugh. We were like, oh, here we go again. And then we said, we wrote back and we said, no, we respectfully disagree. And we said, it's really important that we keep the title of shame. And it's really important that we continue using this title directly as a way of destigmatizing it, right? We just said that's not okay with us, essentially. And we said it very respectfully, and well, we'll see. This is the title we anticipate will be published. Okay, so the fourth barrier is shame itself. And I use it here as a barrier. I more and more see it as just this phenomenal opportunity. I mean, if you work with this emotion in ways, you have struck gold. And you have struck academic gold, that's for sure, because there's just a world of opportunity out there. But there's so much to explore and understand with this emotion, and that makes it really hard sometimes to wrap our arms around. I mean, it's just, I think of it almost as like this nodal concept. Maybe there's a core somewhere in some of the universal elements of this, but even at that, there's too many different ways it's experienced, and then each node goes to some other node and touches some other node, and it's like you never get to the end of what's possible with this emotion, right? And that's amazing, and it's also really hard then to think about, well, how do we capture this in a way that's meaningful for people, that makes it less scary and overwhelming and risky, and makes it something that we should all be doing as a norm within our work and our daily lives. A norm is engaging with this emotion. All right, so how might we do that? And I'm going to just take you through a couple of brief thoughts, and then we'll finish up. I mean, the first, in addressing the dominance of constructs that can be measured and talked about, the first, most obvious one is we just have to keep talking about this. I don't need to convince this group. What I will maybe try and impart is that not only do we need to always talk about, we need to never talk around it. And I'm not saying you go and shove shame down everybody's throat all the time. We need ways in talking about shame to bring people into that conversation that is not reflexively off-putting. You know, when we train people on how to do that in clinical encounters and things like that, we give them other language to use. You know, not are you feeling shame necessarily, but how are you feeling about yourself? Are you feeling down on yourself? Are you beating yourself up, right? Things like that. And we need to label it when we can. There's no other way to destigmatize this word than to start using it. Every time we avoid it, we just reinforces the stigma around it. And we need to normalize it, okay? We don't need to normalize shaming, and you know that shame is always a good thing and should always be happening. We need to normalize it as a human experience that is fundamentally reflective and definitive of our humanity. And that's its role as an evolved emotion, right? We've all evolved this capacity to feel it. We need to respectfully push back when people tell us to stop talking so much about shame, or when they ask us to talk about something more comfortable, right? It's not that we need to go and shove it down their throats. We have to all cultivate the ability to talk about this in ways that pull people in, as opposed to pushing them out. And we've experienced both of those. I experienced it 2 weeks ago in Long Island with a very old, cranky physician. And it was a real moment of clarity for me that not everyone is going to resonate with this topic in the ways we talk about it, even with sensitivity, right? But that doesn't mean we talk around it. Okay, we've got to be able to respectfully push back on that. And then this is my own pep talk, Luna, our pep talk. If there's anybody that the hardest people to convince right now that this is an important thing are people with money that they have to fund your work. Publishing a paper, getting into a conference, holding a forum, doing a workshop, that's easy compared to getting people to fund your work for shame. That's where I think real fear lies. And I think that just is grit. I've just learned that it's just grit. You got to just get knocked down over and over and get back up, write a better proposal next time, go to another funder, and we just got to keep going. You hear that, Will? Got to keep, not give up. We need to fully leverage diverse research methods. The more I hang out with Luna, a philosopher, right, who's new to my orbit, I wasn't hanging out with many philosophers before. I'll say things like, this thing about shame causes a skewed frame of reference. It makes us kind of see ourselves in discordant ways with objective reality. And then she'll stop and say, hang on a sec. And she'll say, what is objective reality? Oh, no. Days, weeks later, I'll come back and say, all right, I think I have a revision of this concept. Diverse methods, frameworks, paradigms are critical to advancing this topic, okay? I mean, this room is filled with that. This conference is filled with that. It's so inspiring, and we need to uplift each of those forms of, research methodology, even if they aren't really in line with our paradigms and ways of thinking or our training backgrounds. And that's really a message that we need to carry out to the rest of the world. This group is going to understand that. I felt it all week, but the rest of the world doesn't see it that way. And we need to not resist the dominant paradigms. And I've started to really appreciate the importance of this. Healthcare, people in healthcare have traditional entrenched ways of communicating about science and knowledge, and we've got to be able to find ways to communicate on those playing fields, right? It doesn't mean that we sell ourselves out and all become quantitative psychologists, experimental psychologists. It means that we expand the ways that we can talk about and drive attention to and motivate people to care about these emotions. And using numbers responsibly has got to be a part of that. And I've resigned myself to that. It's just not going to get us to the level we need in the conversation without that. So we had to create ways to measure it. And I put an asterisk here because this is fraught. I mean, I'll tell you, I went through the ringer creating, this is the scale that was mentioned yesterday, 4 years at least to figure this out, 2.5 of which were just getting over the fear of having a bunch of psychologists just poop all over it. And and really, because this is, if you look in the psychology literature, it's a mess of how to measure this stuff. And it's because it's so stinking hard to measure. So getting over the fear of that, we're just like, let's measure it in some way, right? And this is my mentors just really helped me with this. This is a shame frequency scale. It takes elements of the phenomenology of shame, creates an aggregate score, and it looks over the prior 3 months, and it is by far from perfect, if that existed. It's also got really good validation data for it. So we ran a couple experimental studies with it. It works really well psychometrically. It correlates with burnout and anxiety and depression, and inversely with emotional thriving. We ran some, sub-hoc analysis sub-analyses that shows that it increases with, the more diverse you are from a white heteronormative cisgender male, the higher your shame scores go. This is a place to start, especially in medical education. We need to begin coming up with some basic numbers to say this is a real thing, knowing all the while that we know it's real, but many other people are not going to respond to our cries from the rooftops. To deal with the complexity, we have to find some anchors. I think the anchor that we've really landed, many of us have landed on, is the humanizing nature of shame, right? I mean, it crosses so many things, but at its core essence is the very unique human nature of this emotion. We have to, how it affects learning, how it affects the experience of being underrepresented or marginalized. We need to find those anchors that cross the nodes. And at the same time, we've got to attune to its inherent complexity. Creative professionals, oh my God, they are the answer to the engagement and outreach piece. They do so much more than we can do with words and papers. You've seen evidence of that throughout this conference. And then we've got to collaborate more. I didn't have time to include the sort of the Western dominant perspectives on shame that are developing through our literature, right? There are non-Western global South perspectives that are developing much, I would say a little bit more slowly, and it's because we're not collaborating enough. One just project I'll highlight to make those last 2 points is the graphic medicine work we did. And one of those comics being with a student from the Duke in US in Singapore. We got a Singaporean artist and we said, draw this, create this that is reflective of your culture, your language. They have, some of the terminology and lingo, and they define them. This is a bridge to research, collaboration. Creating cross-cultural understandings has to be a part of this too, right? We cannot be exclusive of our understandings and our work in this field. So if collaborating is maybe where I'll leave you, I think this is maybe a point of mourning for all of us. The Shame in Medicine project is ending, or will end. 1 year. Yeah, I mean, but in a year, this project's going to end. This was, for me, a catalyst. This project was what made me think, oh, this is a real thing. I remember thinking when I came across it, I've got to get in their orbit. Somehow, got to get in this orbit. We've all probably felt that. And it's been a unifying project and group, and the belonging you all have instilled in the work and the quality has been so inspirational. And it's been, without it, we wouldn't be where we are with the work on shame in healthcare. And that's true. And it's ending in a year. So we're going to need to think as a group about how we want to advance this collaboration further. How do we create networks, et cetera? One tiny little pilot step we're going to take, and we're intentionally making this as low key as possible so that we don't shoot for the sky and then not have a chance to do it because we're all too busy. We're just going to create a quarterly set of webinars, and it's coming out of our shame space work. Susie Sterling, Sandy Miles are both going to be co-leading this. Penelope Lusk is co-leading this. Penelope's in the back. With Luna and me, it's not an exclusive thing. We're just going to make sure that, people are there when they say they're going to be there. We'll help find speakers. It's mirrored in some ways off the Kindness Network, which has created this phenomenal network of physicians and healthcare professionals, patients even, that come together to talk about an important topic. So I would really encourage you, this is a bigger QR code. This is just to sign up, send us your email, and we'll send you the invite in an email with the links to this. Even if you don't think you'll come, sign up, because you may find that at that time it's something you really are needing and wanting to engage in. Hopefully, with some, good communication and a real intention to collaborate, we can keep the work of the Shame and Medicine Project going. So with a final thank you to all of you, and to you, thank you so much for the chance to speak.
All right, we are running slightly over time. Do you need to go, Matthew? You can pass that to Alice. Thank you so much, Will. We're going to open it for questions. So our scheduled end time was 4 o'clock, and it is now 5 to 4. So if you do need to leave on time, please just go. Otherwise, we'll probably run over 10 minutes, and I'll just keep my closing remarks very short. So do we have any questions in the room? Yes.
So first, thank you for, I'm in the psychology area, so I really get what you're saying about like the articles and how like we need to prove things that we all experience to be valid. But it really got me when you said that clinical psychologists were afraid of talking about shame or even ashamed of talking about it.
Yeah.
And I was thinking about the first presentation yesterday that in psychotherapy training, we also have that expectation that we cannot have mental problems as mental health workers. And that doesn't work because we're all human. And it's not a question, it's more of a comment. And I think I have a hypothesis of why is it so difficult to talk about it. Maybe it's because it brings vulnerability to the conversation, our vulnerability. But I wanted to share that in my experience with my patients, it has been really powerful to disclosing some affective experiences that I've lived and they are living, and we connect through being human. And sometimes that's what's lacking in research and in clinical settings. And I just wanted to thank you for pointing that out and closing the whole event with that, like reflective thinking. Yeah. Thank you.
Of course, yeah, it's such an important comment, and I think that there's some prevailing notions and ideologies about how we're supposed to be, and one of the more, I think, damaging ones is that we're supposed to be detached, and that's a paradox. I mean, it's actually not possible, and so you're asking us to do something that's inhuman, right? And now we have to be very careful about any level of reductionism, right? So being completely detached or being completely open, neither is right. I think their patients, deserve to not have to take our own suffering on them. I couldn't agree more as a clinician. I share with my patients, the ones that it's safe to do so, and when it's appropriate, some of my own struggles. I'm on an SSRI, Zoloft, for anxiety. If they're really struggling with it, I'll tell them, I take this and I've been okay, and I just want you to know that other people take it. Things like that. Not only does it, I think, help that therapeutic encounter, but maybe more fundamentally, it helps me, right? I mean, I walk out feeling cared for, and I feel like I matter to them. And that's a good antidote to some of the burnout that our systems drive.
Is there an online?
How do you think the current era of EDI rollback impacts our attempts to make staff shame a routine part of clinical education?
The EDI rollout is, it's massively harmful. There's too much to talk about. There's so much harm going on in modern culture, and the United States is unfortunately the epicenter of it right now. I'm a eternal optimist, so I always try to find the opportunity even in hardship. And I actually think that shame is a bit of a sneaky inroad to addressing issues of EDI at a time where you can't do that, right? Where you can't use certain words. I don't know if shame's on the banned word list in the United States. I mean, there's a banned word list for federal funding. I don't think it's made it on there. I hope not. But shame touches all of those things. Can we maybe create a conversation around self-consciousness and shame that also touches on identity, marginalization, and it acknowledges all those parts of the human experience without, getting turned off or shut down? And so I do think we have an opportunity there to somewhat insidiously bring that conversation to the fore through this approach.
Thank you. Any questions in the room?
Thank you, Will. It's about further thoughts going forward. Which other research disciplines have you not worked with yet, which might have some funding for you?
Yeah, gosh. This is part of the challenge, I think, of figuring out what to study and when, and what do you prioritize? I mean, there's grantsmanship. You kind of fit your project to the grant, and so you can fit shame to almost anything. Really, it's a real opportunity, and it's a bit overwhelming. I think it's less what topics in the States right now. It's what's topic. It's more which funders. Foundations, industry, commercialization is definitely something that we're looking at. Is commercializing training products and resources, potentially creating sustainable, revenue that isn't living and dying by grants, that allows us to do work with its scalable impact. So I think we're having to think outside the box about that quite a bit. The EDI realm is off limits right now. Unfortunately, it was so much good funding was coming through that. Error is a big one. I think error has one. Patient safety is one. Even I think belonging still has a role to play with this. And then the real tip of the iceberg is patient-centered outcomes, right? I mean, what does shame do at the level of the patient and their outcomes? And there's a smattering of data on that, but very little of a robust data set. So I think looking at shame in patient care is especially untapped. Yeah, there's opportunity, right? So I think we still need to just full steam ahead.
Thank you. We've got one more online question, and then I think that will be the last question, and then anyone in the room can chat to Will after.
Given that shame is intrinsically tied to trauma, major and minor, and culturally bound, could you speak to a cross-culturally trauma-informed and sensitive approach to destigmatization?
Yeah, a great question. I wish Luna was up here to answer it. She wrote the article on it. Matthew wrote the article on shame-sensitive practice as being an umbrella under which trauma-informed care is nested. Not all of us will experience trauma in our lives. Every one of us has the capacity for shame and probably will experience it. And there's so much to be learned about trauma-informed practice through shame-sensitive practice or shame-competent practice. So I think there's huge opportunity in advancing trauma-informed care through a shame lens. And I just have to say Luna is doing kind of really world-leading work on that, working with police forces and trauma-informed networks here in the UK, social workers. So it's actually a bit of an underexplored area, shame and trauma, believe it or not. There's definitely some association there, but the degree to which it is important and matters is under acknowledged. So huge area. I would just make a pitch for shame-sensitive practice or shame competence as a way to begin maybe implementing trauma-informed practices through a different lens. Thank you so much. Yeah, thanks.
I'll just say a few words just to wrap up and close the event, and I apologize that we're running over time. Thank you everyone online and in the room for bearing with us. So first of all, I'd really like to thank everyone for coming, all our audience members, all our speakers, all our poster presenters. Many of you have traveled from very far away, which has been wonderful to have us all together in the room. And I'd really like really sincerely like to thank everyone for engaging professionally, coming to an academic conference in a university, but really showing up personally and being here as a full human. And there was so much sharing and connection, and it's been amazing. I really have been moved. I've had lots of really lovely conversations, and there's a lovely community of people. I'd really like to thank the Wellcome Trust for being visionary and funding this project. And I think, as Will indicated, it's quite unusual for a funder to take a topic like this seriously. And I think working with Barry over the years, somehow we got them to take us seriously. I don't know how. Maybe because you're an anaesthetist. That's why your high status role as an anaesthetist. So I thank Barry for his high status and walking alongside me as a lowly philosopher. You can stay in touch with us. The QR code that we'll put up is just an effort to keep a kind of quarterly conversation going where people can meet in a Teams call. We're trying to do it at a time like the Kindness Network does, which is like 6 p.m. in the evening, so it's good for many time zones. And different speakers will come. And Sandy and Susie have really been spearheading that. And I thank you both for your ongoing interest in shame and always reaching out to us to encourage us to do more. So that's really great. You can also join our Shame and Medicine mailing list. So if you just go onto our website, if you're not already on it, and I presume many of you are, you just have to click a button, enter your email address, and then you get our newsletter. Alice sends it out every 6 weeks, and you can stay abreast with publications, events, and other activities. What else do I have here? Thank you to Emily and the tech team for making this all run very, very smoothly. I think yes. Thank you to the Shame and Medicine team, Matthew, Barry, Stephen, Farina, Arthur, Juanita, Mary, many of whom had to already leave. And lastly, obviously, Alice. Alice has made this whole event possible. Everything has run so smoothly. If any of you have ever organized an event, there are so many moving parts and so many things to remember. And not only has Alice managed all of that, she's done it flawlessly and beautifully. And it's just been great. Down to like our little name tags at the dinner with our food options, because we'd have all forgotten like everything. And she's done it just graciously and all. Yeah, thank you so much, Alice. And she's definitely been the star of this event and made it all possible for us to be here and connect in this way. So thank you all for coming. And I hope to speak to you all again and see you all again. I know many of you I will. So yeah, and please feel free to email me or get in touch with the project. If you'd like to write a blog post for our project, we'd happily receive one. And yeah, please stay in touch. Thank you all.